15, no? Yeah, I think we are on time. So I invite Dr. Subhajit Chakrabarti for presentation of Fraser syndrome, a rare case of syndromic cryptophthalmos. Present? Presenter is not there. Okay. Next, I will call again Subhajit Chakrabarti. Presentation is on pediatric penetrating keratoplasty, retrospective study for prospects in a tertiary eye care center. Not there. Okay, make it. If they come in time, I mean afterwards also we can give the opportunity to present. Then next I will call Kruti Nusaran. Yeah, please come, no? Our presentation is on accuracy of retinomax versus cycloplegic retinoscopy for measuring refractive errors in children.
Okay, very good evening. I will be presenting accuracy of retinomax K plus versus cycloplegic retinoscopy for measuring refractive error in children. As we all know, refractive error is the most common cause of treatable blindness. And we also know that table-mounted autorefractors have been there and we are using them. But the problem in pediatric age group is that the lack of cooperation and lack of portability. Like if a child of age 1 or 2, or if you want to go on a screening in community, then tabletop autorefractors cannot be helpful. Also, cycloplegic retinoscopy requires an amount of skill that we cannot teach a ground level worker. So Retinomax is a handheld autorefractor that enables quick estimation of refractive errors, and it's useful for screening in children. So the aim of our study was to investigate its accuracy versus the cycloplegic retinoscopy, which we have considered at gold standard. We compared these results under both non-cycloplegic and cycloplegic conditions with Retinomax, and then compared it with cycloplegic retinoscopy. So something about Retinomax, designed by the Nikon. It is a handheld autorefractor. It also gives keratometric values, and it has a wide range from -18 to +18 of sphere and cylinder. It is just 1.08 kgs, very easily operable, and works on a retinoscopic principle. It has two modes, standard mode and rapid mode. So to reduce the accommodation, as used in other autorefractors also, we have fogging technique, but the quick mode, it disables that technique and gives us quick results. So we did it at 5 meter distance. This is the picture of the Retinomax, and at a distance of 5 centimeter used for the patient. And so we took children from age group from 2 to 12 years with clear lens, and we also took pseudophakic patients with clear visual access. We took 100 eyes, and in phakic eyes we divided into 3 age groups, 2 to 4, 5 to 8, 9 to 12. We estimated first non-cycloplegic, took sphere cylinder axis values. Then we induced cycloplegia and again did Retinomax, and then finally cycloplegic retinoscopy. Both time were noted. So the outcome was divided as in different age group and pseudophakic group. We used our basic pair t-test and standard deviation, and we also used bland Talman plots, which gives a correlation of two methods very nicely in a graphic form. So we had 70 phakic eyes, and mostly were between 5 to 8, 60%, and rest were 2 to 4 groups and 9 to 12. So this is the graph summary of the tabulated form of phakic eyes. And here, what I want everyone to see is the difference we had in non-cycloplegic and cycloplegic. This is the value of the Retinomax, and this is the sphere. So when used with cycloplegia, it was very well corresponding with retinoscopy, but in non-cycloplegic form, we were getting a lot of difference. But the cylinder and axis values were corroborating either used with cycloplegia or non-cycloplegia. Similar representation here. So these are the sphere values we tabulated in different age groups, and clearly in 2 to 4 and 5 to 8, the difference was clinically significant, less than 505 is taken, so that 2 to 4 age and 5 to 8 non-cycloplegia cannot be used. But in 9 to 12, even non-cycloplegic retinomax was giving a good value, and we can use it. So now another thing we used was a clinical significant difference. So sometimes the statistics, they don't correspond to what we see in clinics. So we saw the difference of we took 0.5 as a clinically significant difference, and we saw that in sphere, when used with non-cycloplegic retinomax, 65% cases were clinically significant difference was there, which is a large difference, and which was reduced to only 17.5% when used with cycloplegia. All indicated the same things. These are the bland almond plots. These are the two lines between which, if your points are lying, then there is a good agreement between two methods, and if these points are on the central line, that means the best correlation. So when comparing non-cycloplegic retinomax with retinoscopy, points were lying in between, but these points were lying on central line, which was showing a much better correlation when used with cycloplegia. So our study showed that in phakic eyes, as we all already know, that with cycloplegia, if you're using this autorefractor, it will give good results. But in 9 to 12 children, you can use it without cycloplegia also. And next was pseudophakic group. Pseudophakic group, we see that all the values were within, it was collaborating well with or without cycloplegia. We all know it doesn't matter. But a difference came in axis values. A very large clinically significant difference was seen in axis values in pseudophakic eyes, and we could make out the difference was due to post-operative irregular astigmatism and low retinoscopic result that resulted in this kind of difference. So time taken was definitely more with cycloplegic retinoscopy and very less with retinomax. To conclude, you can use your retinomax in phakic eyes in older children without cycloplegia, and in pseudophakic eye, this is a very dependable method. Thank you so much.
Yeah. Now, finally, which you feel better? I mean, the cycloplegic refraction, or directly you can go with retinomax? In what cases it is?
Yes, sir. So after doing this, I can say that retinomax is a very good device to use if you are using it with cycloplegia. After inducing cycloplegia, it is very well in phakic eyes. Okay. Pseudophakic eyes, we don't need cycloplegia, so you can very well use. Pseudophakic children need repeated refractions, so it was very easy to do that with this device.
One more question is, any added advantage is there, especially in children below 5-6 years of age with retinomax?
Sir, that was the point, that they don't, the attention span of these children is very less.
That's why, can it be applicable in those age group? See, elderly children, anyway, you can do it.
Yes, sir. So in that younger age group, they don't let you do retinoscopy for a very long time. So that we need a device that can give a result in like 10-15 seconds. So that retinomax was able to do.
Okay, thank you so much.
Thank you, sir.
Nice presentation.
Yes, sir. Yes, sir. Sir, it is an handheld autorefractor. Can be used in adult children. It's just an autorefractor. Children, sir, yes. Children, but I'm sorry, sir. Sir, in age group above 9 years, we found that it was giving good results. That's why we divided that kind of age group. I cannot be very sure that above or below, it might be a margin. But above 9 year, non-cycloplegia, without cycloplegia, it was giving good results. But less than that, definitely overestimation of myopia was there, which was reduced after giving cycloplegia to the child.
Okay,
and
sir.
Only cylindrical power, that means astigmatism is very correct in the 9 to 12 years, about the 9 years age group. In previous studies, it shows that non-cycloplegic using retinomax, it is very much equal to the cycloplegic retinoscopy in cases of astigmatism cases, but not with the spherical equivalent. And the spherical equivalent is somewhat more when we measure with that retinomax.
In younger children, ma'am?
No, in older children.
In older children?
Older children also, you are telling that we can take it as
Yes, yes.
without cycloplegia.
Yes, ma'am.
But in previous studies, it shows that only for astigmatism they are considering.
Yes, ma'am, definitely. As normally we use autorefractors in children, like in even to 12 and 15 years, we prefer retinoscopy cycloplegic, considering they have some sort of accommodation. But my study, I would say that I had only like 15 to 29 to 12-year-old children. So for that, I got good results. But definitely a large number should be there.
Okay, thank you.
Thank you, ma'am.
Next presenter is Dr. Sumita Mohapatra. Madam.
A very good afternoon to one and all. This is Dr. Elisa, a first-year resident, going to give a talk on the free paper on the topic Dry Eyes in Pediatric Juvenile Idiopathic Arthritis, a study. I do not have any financial interest to disclose. JIA is basically a non-infective autoimmune inflammation of joints involving more than 3 on most occasions for more than 3 months, most commonly seen in 7 to 12 years of age. Ocular manifestations can be in the form of glaucoma, uveitis, iridocyclitis, and dry eye syndrome, which I am going to talk about. It could be due to the autoimmune destruction of the glands forming the tear film. Dry eyes in JIA is basically a very underreported ocular problem, as this young minds are not able to perceive the symptoms and they are not easily screened looking just for dry eyes. However, if this is left untreated, it can have a detrimental effect in their following years to come. So my aim was to study the prevalence of signs and symptoms of dry eye in pediatric population with JIA. It was a tertiary healthcare-based observational cross-sectional study over 3 months from March to May of this year. All diagnosed cases of JIA using the ILR criteria by a pediatric rheumatologist was done, and it was referred to ROPD for ophthalmic evaluation. Patients with other forms of arthritis, aged less than 6 years and more than 18 years, patients with any other ocular surface disorders or inflammatory disorders, history of ocular surgeries or trauma, and usage of medication causing the dry eye were excluded. After this criteria was set up and after informed consent was taken, 38 children with JIA were selected and as the case group, and 38 age-matched control was taken with no pre-existing ocular disorder from the same OPD. After selection, complete ophthalmologic evaluation for dry eyes were done with more emphasis on symptoms analysis, for which I used a questionnaire, that is the OSDI questionnaire, and this is the grading how it is to be done. This is the questionnaire, which includes 3 components, that is the visual related symptoms, the ocular symptoms, and the environmental triggers, which is very important in this case because it's an adolescent group which all the environmental triggers are mostly done by them. Then comes the TBUT using the fluorescence test, where normal more than 10 seconds were taken as normal. Then was the Schirmer's test, one without the anesthesia. Then corneal staining for looking for punctate epithelial erosions. After the examinations, data were analyzed and p is equal to less than 0.05 was statistically significant. Coming to the results, as you can see, in age, both the groups, cases and control, both age and gender are matched, and in both cases, female preponderance is there. Coming to the mean scores of OSTI, that is 19.39, which and 19.39 in the case group and 9.63 in the control group, which is very statistically significant. As you can see in the case group, there are 23 people falling in the mild category, which is a very important thing to be marked here. In TBUT, again, the mean score for case were score for the test in the case group were 9.8, and for the control group was 13.5, where the p-value was again less than 0.05. In the case group, the abnormal TBUT was shown by 12 people, where 4 people, that is 10% of them, showed severe dry eye. Severe dry eye, which was 10%. Schirmer's test again we can see in the case group, the mean score came up to 12.5 and the control group was 20.3, which is again significant. In Shermer test, in the case group, the abnormal Shermer test was shown by 10 people where 4 of them showed severe dry eye. This is the table showing 31% in the case group showed positive to beauty and 26% showed positive Shermer. So this is the prevalence of the signs that was seen. When it was about the corneal staining, 6% out of 38 people, 38 people was seen positive for Ps. So in my case, oligoarthritis was the most common type of JIA found, and this is the most common type where ocular complications are also most common. The increase in mean score of OSTI shows more in the JIA group than the controls, where 60% of them fall in the mild category, so the subjective symptoms are more common. And 31% of them showed abnormal TBUT, 26 showed abnormal Shermers, 15% showed corneal lesions. They had more, like I said, they had more symptoms than the signs present. In the studies, you can see there are 20% and 26% compared to my group. Coming to the conclusion, I would like to say that it's a very commonly underdiagnosed situation in the pediatric age group. So I would like that it's a wholesome approach of pediatricians, rheumatologists, and us ophthalmologists to try and look for it actively so that they don't land up in complication related to that. These are my limitations. Thank you.
Thank you. Any single most sign or symptom which is a pointer towards us to pay attention on that aspect?
So
Can
while
you
I was doing the
suggest?
study, most of them complained of if you talk about the symptom, it was mostly a foreign body sensation or itching, which was very subjective because they are young people and they couldn't exactly describe.
Yeah.
So I would, that's why I took OSTI score and I saw how it changed with the environmental triggers. Coming to science, I would like to say TBUT is more confound because one single Shermer cannot diagnose or rule out dry eye.
Very nice presentation. Thank you.
Correlation between the, did you find any case and severity of the dry eye during your study?
Ma'am, that wasn't a part of my study, but on the basis of history, when I was taking and doing the history as such, all of them had active arthritis and their ANAs levels were high. Though I did not statistically represent it and include it in my study because it was just on signs and symptoms, but while taking history, yes, they had more active arthritis involved and not treated. So yes, there is a
Thank
connection.
you. Thank you so much.
Thank you, sir.
So next, Jigar Joshi. A case report of 2 siblings with microspherophakia associated with Marfan syndrome. Not there, Jigar Joshi. Absent. My God. Next, I invite Smruti Nagarajan. Suriti Nagarajan, sorry. Change in refractive error and corneal topography following horizontal strabismus surgery.
Good afternoon, everyone. So I'm here to present my topic on changes in refractive error and corneal topographic following horizontal strabismus surgery. So I have no financial interest in this presentation. So strabismus surgery, as you all know, it is most commonly performed procedure is on the horizontal recti muscles, which is primarily aimed at restoring the potential vision of the patient and also in providing better cosmosis. However, even with the best surgical outcomes, patients still have visual disabilities. The pathophysiology behind this is when you are doing an horizontal strabismus surgery, you cause change in the insertions, which causes alteration in the tension of the recessed muscle, and that causes changes in the forces acting on the sclera, in turn causing morphological changes in corneal curvature. So our objective was to compare the preoperative and postoperative refractive error changes by cycloplegic retinoscopy, and also to compare those values with corneal topographic changes using pentagram. So we had a sample size of 50 patients aged from 8 to 35 years who were diagnosed with concomitant exotropia or an esotropia and who underwent an unilateral horizontal strabismus surgery. We excluded all the patients who had any history of previous ocular surgery or any other intraocular pathology who required a vertical strabismus surgery and ocular trauma. So the pre-op evaluation included best corrected visual acuity, a thorough squint evaluation, both motor and sensory evaluation, a thorough cycloplegic refraction, anterior segment evaluation, and corneal topography was done using pentacam, and fundus evaluation, and they underwent strabismus surgery by a single operated surgeons, and they were followed up over a period of 6 months. So statistical analysis was done in SPSS software. A paired t-test was used to assess the preoperative and postoperative variables, and a p-value of less than 0.05 was considered significant. Coming to the results, among 50 patients, there were 32 males and 18 females, and 84% was operated for an exotropia and 16 for an esotropia. So among the population, 26% already had a pre-existing compound myopic astigmatism and 22% were emmetropes. So the mean preoperative and the postoperative visual acuity using logMAR chart revealed no difference in the visual acuity changes. The mean spherical power at pre-op was -1 diopter and over a period of 6 months was -1.03 diopter, which showed a slight myopic shift. The mean cylindrical power was 0.6 in pre-op and it became 0.73 in 6 months of follow-up, which also showed a myopic shift, but it was not significant. The average anterior corneal curvature, the mean was 44.67 at pre-op and it was 45.01 at 6 months follow-up. It was in the normal range. The mean corneal thickness remained normal throughout the follow-up period. So coming to the discussion, the first study was done by Don Marshall, and he compared it with the operated and the non-operating eyes, and he identified that 60% of the squint operated eyes had astigmatic changes post-operatively. So next came Preslin. He also did the same study, and he proved that there is no significant change in the spherical equivalent. However, there was a temporary change in the astigmatic power at 180-degree meridian axis. There were other studies done by a lot of authors, and the literature says that there is a transient astigmatic change which is seen over a period of 6 weeks to 3 months, which settles over a period of 6 months. Corneal topographic changes was again done by Nadi et al., and he also proved that there is an increased astigmatic power at day 1 of post-op, which was reduced by 1 month. So to conclude, yes, horizontal strabismus surgery may cause a transient myopic shift and increased with the rule astigmatism, but the magnitude and surgical technique do not affect any of these findings. The refractive changes in the strabismus surgeries are usually insignificant. So as an ophthalmologist, we should be aware of this preoperative things and postoperative changes which can happen, and we should counsel the patients and give them reassurance that whatever change is going to happen is only transient. And anyways, they can undergo any of the other corneal procedures safely even after a strabismus surgery. Thank you.
Very good. Yeah, it's only transient changes.
Yes, sir.
I don't find any permanent changes.
Yes, sir.
Yeah. Okay, Amma, thank you. Thank you for the presentation. Next, Dr. Shrutakirti Parida. Effect of low dose atropine in choroidal thickness, children with myopia progression.
It's not coming to slideshow. Slideshow mode.
A very good afternoon to one and all. Today I will present a paper on the effect of low-dose atropine on choroidal thickness in children with myopia progression. I have no financial interest to disclose. So this was a prospective case control study which was done in the Department of Ophthalmology, KIMS Bhubaneswar, to determine the effect of low-dose atropine on choroidal thickness in children with myopia progression and to compare the rate of myopia progression in cases versus controls in terms of the changes in spherical equivalence, axial length, best corrected visual acuity, and choroidal thickness at presentation and subsequent follow-ups. So we took 55 cases and 55 controls aged 5 to 16 years with bilateral progressive myopia, out of which 44 cases and 43 controls were included, and the rest participants were excluded as per these exclusion criteria. So in the 87 children were randomly assigned into two groups, in which 44 children in group A received once daily dosing of 0.01% atropine at bedtime, while 43 children in group B received once daily dosing of a placebo eye drop at bedtime. And the minimum duration of follow-up was 6 months. Statistical analysis was done and a p-value of less than 0.05 was considered to be significant. Now coming to the results, the demographic parameters were comparable in both cases as well as the controls. Now coming to the spherical equivalence, the cases showed a decrease in the spherical equivalence from presentation to at 3 and 6 months of follow-ups, which was statistically significant, whereas the controls showed an increase in the spherical equivalence from presentation to 3 and 6 months of follow-up. Similarly, in the axial length parameters, the cases showed a decrease in the axial length from presentation to 3 months and 6 months of follow-ups, whereas the controls showed a statistically significant increase in the axial length at 3 as well as 6 months of follow-ups. Coming to the subfoveal choroidal thickness, we also found that there was a significant increase in the subfoveal choroidal thickness from presentation to 3 and 6 months of follow-up in the cases as compared to a significant choroidal thinning in the controls at 3 and 6 months. There was a declining trend of the best corrected visual acuity in the controls at 3 and 6 months follow-up as compared to an improving trend of the best corrected visual acuity in the cases. We tried to correlate the spherical equivalence and axial length with choroidal thickness at 3 and 6 months of follow-up and found a positive correlation between the spherical equivalence and axial length with subfoveal as well as choroidal thickness at all the quadrants in the cases group, whereas in the controls there was a negative correlation, but this was not statistically significant. So now coming to the discussion, let's see what are the outcomes of our study. We found a significant decrease in the spherical equivalence as well as the axial length in the cases group at 3 and 6 months of follow-up, whereas there was a significant increase in the spherical equivalence as the axial length in the controls, which signified that there was a significant myopia progression in the controls as opposed to the retardation of the myopia progression in the cases group. The low-dose atropine significantly increased the subfoveal choroidal thickness as well as choroidal thickness in all quadrants in the cases group at 3 and 6 months of follow-up, whereas there was significant choroidal thinning in the controls group at 3 and 6 months of follow-up. There was also a significant improvement in the best corrected visual acuity in the cases at 3 and 6 months of follow-up as compared to a declining trend of best corrected visual acuity in the controls group. There are various studies which were done by Sander et al. In which they concluded that low-dose atropine inhibits the short-term effect of the hyperopic blur on choroidal thickness, and when it was used alone, it caused a slight thickening of the choroid in the young, healthy myopic eyes. Similar study done by Wu et al. Also found a significant increase in the subfoveal choroidal thickness in the group which was treated with atropine, and they found a significant relationship between the changes in the subfoveal choroidal thickness and central corneal thickness. And these studies were at par with our study, but a study which was contrary to our study were done by Wu et al. In which they found that 1% atropine increased the choroidal thickness, whereas 0.1% at 0.01% atropine caused a decrease in the choroidal thickness after 6 months of treatment. There are various limitations of our study, like less sample size and lesser duration of follow-up, and we didn't take into account the pupil size and accommodation amplitude as well as other risk factors for myopia progression. So to conclude, low-dose atropine is effective in retarding myopia progression in children, and there is a need for further studies with larger sample size and longer duration of follow-up, along with need for studying the rebound in myopia progression after cessation of the drug. Thank you.
What was the normal value of choroidal thickness? I mean, what is the OCT? Which one? What is the instrument that is used to measure the OCT thickness?
So we use the normal SD-OCT to measure the choroidal thickness at the subfoveal level as well as at the 1500 microns and 3000 microns in all the quadrants, superior, inferior, and temporal and nasal to the fovea.
Okay. And then another thing is you could have done contralateral study, no, in the other eye. I mean, keeping that as a control.
Yes, sir, we are planning for doing the contralateral study in the other eye.
I
We
think
have
that
just
would have
started the
been
study. Yeah,
better option rather comparing to groups.
yeah.
But
Yes, sir, we are next planning to do that. Like we will take atropine in one eye and the other
Yeah,
eye we
yeah.
will put a placebo drop, and we
Yeah,
are on the verge of doing
yeah,
that.
that is I think better. Anyway, it's a good study. Thank you.
Thank you, sir.
Lakshmi, demographic profile of preterm babies with APROP at Tertiary Care Pediatric Hospital in Telangana.
Good evening, everyone. First of all, I thank the dignitaries for giving me the opportunity. So, what is APROP? APROP is a rapidly aggressive form of retinopathy of prematurity, and the clinical features are characteristic and different from the classical ROP. The disease may rapidly progress to stage 5 ROP if not treated in time. What actually does a APROP patient look like? He has capillary loops. Which are these loops which do not progress further. There will be an avascular retina. Then there is dilatation and tortuosity of the retinal vessels at the posterior pole, along with vascularization at the junction of the immature and mature retina. Why is it important? Because unlike the other stages, staged ROP, APROP directly goes into stage 5 and the patient may have blindness because of the undetected APROP. When we are looking at APROP, there are two zones which we have to look in. Those are the zone 1, which is the central zone, which is a central zone which is marked by the radius of distance between the optic disc and the macula, double the distance if you take, that is called the zone 1. And then zone 2 is the distance till the nasal ora serrata, and zone 3 is a small peripheral swivel which is present in the temporal ora serrata. So these generally the zone 3 usually forms by 44 weeks of birth. So these preterm babies who are born much before, they are very they will have lot of immature retina, and they are also susceptible to lot of turbulent early neonatal period, because of which they may develop ROP. ROP occurs usually in two phases, in which they have initially their relative environmental hypoxia in the phase 1, which is between birth and 4 weeks, because of which there is vasoobliteration and hypoxic peripheral retina. And because of this hypoxia, in phase 2, there is a secretion of VEGF and insulin-like growth factor 1, which leads to neovascularization. What are the risk factors for ROP? Early gestational age, birth weight, usage of supplemental oxygen, usually unmonitored, and sepsis, infections, intraventricular hemorrhage, patent ductus arteriosus, hypotension are other risk factors which are seen. What is the need for this study? Because of the improvement of the neonatal services, there is a better survival of smaller babies which we are seeing. That means there is an increased risk of number of babies who are at risk for APROP. So we had done a retrospective observational study, and the purpose of the study was to study the demographic features of preterm babies diagnosed with APROP. The place of study is Nilofer Hospital, which is a government affiliated, and it's a tertiary care pediatric center in Telangana. And since we have all the sick babies being referred in the last stages here, we have a lot of babies who are sick and who have all the risk factors for developing APROP. The study period was from March 2020 to April 2021. Babies who were born before 37 weeks and babies who were born at term but who had a turbulent early neonatal period were screened. The screening was done by half diluting tropicamide phenylephrine drops with 50% with carboxymethyl cellulose. Paracaine was instilled prior to examination, and screening was done with the help of an indirect ophthalmoscope and 20 diopter lens.
We included only APROP in this study. Staged ROPs, mature retina and immature retina were excluded from the study. The demographic features which were analyzed were the sex, birth weight, gestational age at birth, age at first screening, and age at the development of ROP. Whenever there is an ROP, it is an emergency, and the treatment management options include anti-VEGF or laser, and sometimes you might need to give both anti-VEGF and subsequently do a laser, depending upon how the baby is responding. We had screened 660 babies during the study period, and out of these, 47 babies had APROP, that constituted about 7%. The incidence of APROP was more in female babies, which constituted close to 62%. The mean gestational age at birth was 30 weeks, with a range of 25 to 34 weeks. Most of the babies were screened within 1 month, and the post-conceptional age, mean age at the development of APROP was 34 weeks, and supplemental oxygen was given in 23% of the patients. 38 patients were given anti-VEGF, 2 patients were given both, and laser was done in 7 patients. If you see incidence of ROP across various studies, it is in India it is around 4 to 5%. This is the limitation of our study, that we do not look into all the neonatal risk factors, and the clinical implication is that APROP is the clinical emergency. When detected, you have to treat the baby within 72 hours, because you have to avoid retinal detachment. These are the acknowledgements. Thank you.
In history, did you take any while testing the babies? Is there any specific you are telling that female babies are more in your study? Is there anything related to that?
Nothing
Gender
very
related.
specific, ma'am, what we have seen, but usually the survival of the babies, sicker babies, it was usually seen as among the babies, these were the ones who were smaller in size, and these were also few of them were twins, and these were the ones who were having the lesser weight. So that's why there would be, and this sample size is a very small sample size. We studied over a very small period. Maybe if we study over a longer period, maybe the gap would have been come down. But otherwise, we didn't find anything much different.
Vijay Lakshmi. Yeah, next I invite last speaker, no? Dvij Shah, Dr. Dvij Shah. Not there. Absent. Then I invite Hemalata, pediatric traumatic cataract, facing the inevitable challenge of in-the-bag IOL implantation.
Very good evening, everyone. Let me start my presentation of intraoperative challenges of in-the-bag IOL implantation in pediatric traumatic cataract cases. Presenter is myself, Dr. Hemalata, and my guide is Dr. Raman sir. Pediatric cataract surgery has different challenges from adult cataract surgery, mainly due to different anatomical and physiological properties of the growing eyeball. Pediatric cataract surgery itself is a challenge, and trauma complications accompanying it doubles the trouble for the surgeon. So few challenges of traumatic cataract are corneal opacities, which not only makes surgical view difficult, but also affect the visual prognosis after surgery. Small pupil makes the rhexis and capsulotomy difficult. Presence of zonal adhesions and anticapsular and postcapsular tear complicates the surgery, as few steps like hydro has to be done very carefully, and they can present as intraoperative surprises too. IOL power calculation is difficult in presence of corneal astigmatism, which can be due to corneal opacities and due to sutures. Few challenges of pediatric cataract are low scleral rigidity, In such cases, when the intraoperative hemodynamics are poorly controlled, it results in collapse of the eyeball. Due to high elasticity of the anterior capsule, there is high chance of peripheral extension of the rhexis. Small eyeball, GA complications, and high intraocular pressure further complicates the steps for the surgeon. So, main purpose of my study is to assess the intraoperative challenges of in-the-bag foldable intraocular lens implantation in pediatric traumatic cataract cases. So, this is a case series where 10 pediatric patients presented to our department were selected and they underwent all the necessary preoperative investigations. Assessment of trauma-related complications like corneal scars, adherent glaucoma, PC tears, small pupil were given special attention. Each case was individually assessed for existing complications and surgical management was tailored accordingly depending on the preoperative and intraoperative findings. All these cases underwent manual lens matter aspiration or phaco aspiration through clear corneal incision followed by foldable IOL in the bag implantation. Patients with posterior segment pathology and patients who had complications which requires single rigid in the sulcus and SFIOLs were excluded. So I want to show few common cases of pediatric traumatic cataract, how they presented to our department and how we tried our best to place the IOL in the bag. So this is a 11-year-old male patient who sustained trauma to right eye with stick 4 years back, presented with irregular pupil, with synic at 4 and 7 o'clock, and total cataractous lens. Vision was hand movements. Intraoperatively, synic were released using venous scissors and iris repositor meticulously. So capsulotomy was done by can opener technique to avoid geoparadising the posterior capsular integrity further. Vision postoperatively at the end of 3 months improved to 6/9 after amblyopia treatment. So next case is a 5-year-old child with history of trauma to right eye with stone, with vision was hand movements. Adherent glaucoma was present at 9 o'clock with total cataractous lens. Intraoperatively, on injecting cohesive visco, pupil was dilated enough and adherent glaucoma was released. We faced difficulty during anterocapsulotomy as we was obstructed by the corneal opacity. Successfully, IOL could be placed in the bag after assessing the PC condition. Postoperatively, vision improved to 6/12 at the end of 3 months. So this 5-year-old child presented with history of trauma to left eye after getting hit to tire, presented with macular corneal opacity, posterior synic A at 11 and 6 o'clock. During intraoperatively, synic A were broken. After using preoperatively, we used atropine eye ointment to break the synic A, and during surgery, syniculysis was carried out using cohesive visco, and after ruling out zonal dehiscence and PC tear, IOL is successfully placed in the bag. Postoperatively, vision improved to 6/6 at the end of 3 months. So this is a 15-year-old female, sustained thunder lightning injury with vision was PL positive. Lens was totally cataractous and fortunately she didn't have any skin injuries. So this case was managed in the usual standard way. Total cataracts like this will mask the condition of posterior capsule, which has to be assessed properly before placing the IOL in the bag. And vision improved to 6/9 at the end of 3 months. So this is a 10-year-old child who sustained trauma to left eye with cricket ball, presented with total cataractous lens. Posterior synic A and anterior capsule rupture was seen. In these intraoperative pictures, we can see the vertically ruptured anterior capsule. Loose adhesions were present between anterior and posterior capsule, which were released, and the opacity margins were trimmed, and IOL could be placed in the bag after assessing the PC integrity. Vision was 3/6/1 at the end of 3 months. So, in the bag IOL implantation in pediatric traumatic cataract cases can be achieved with proper preoperative assessment and instrumentation, which results in good surgical and visual outcome. Thank you.
Good presentation. So in all out of your cases, only one case is having PC tear.
Yes,
intraoperatively you found.
yes, ma'am.
The rest of the cases PC condition was good.
And in that case, the PC tear was only 2 clock hours, ma'am. So we could be able to place IOL in the bag.
Nice presentation, Hemlata. Good work.
Yes, sir. PC tear only in 2 clock hours. Yes, sir. Before in preoperative assessment, we ruled out them. Yes, sir.
So he will be talking on study of the refractive changes and ocular biometrics in preterm and term infants. Welcome you, Ravi Kumar.
Good afternoon, respected chairperson and moderator, and my dear AIOS members. First of all, I thank AIOS for giving me the opportunity to present it again and for the award. My topic of presentation is study of the refractive changes and ocular biometric in preterm and term infants. I'm Dr. Ravi Kumar, and my co-author is Dr. Suchita Parisa. She is HOD at AIIMS Bhubaneswar. I have no financial interest. Newborns with gestational age of less than 37 weeks are prone to various ocular problems. 15 million neonates are born premature worldwide annually. Full-term healthy newborn is generally born with axial hyperopia, and preterm newborn are noted to have myopia, hyperopia, or astigmatism at birth depending upon gestational age and stage of ROP. Previous studies focused on ocular biometry after ocular stability age of 3 to 16 years, and information regarding refractive status in infants in whom dynamic ocular changes are ongoing is still limited. So the aims and objective of the study, the primary objective is to compare the refractive changes on ocular biometric between preterm and term infant in the Indian scenario, and the secondary objective were to compare the refractive outcome in preterm infants with ROP and without ROP, and to study the association of refractive errors with birth weight gestational age. So it is an cohort study incorporating 19 infants, 45 is corrected preterm and 45 term. Inclusion criteria were preterm and term babies born at AIIMS Bhubaneswar between January 2019 till December 2019. And exclusion criteria were babies with systemic comorbidities like severe sepsis, hypoxic ischemic encephalopathy, or on mechanical ventilation, and ocular comorbidities with congenital cataract and corneal opacity, and other syndromic babies were also excluded. In Group A, the preterm baby were enrolled with 37 weeks of corrected gestational age, and their growth parameters and ocular parameters were recorded. And in Group B, enrollment of term infants were done. Also, the growth parameter and the ocular parameters were recorded in that Group 2. And they were followed up at the age of 3 months, and growth parameter and refractive error and ocular biometrics were recorded, and at second follow-up was done at the age of 6 months, and third follow-up was done at the age of 12 months. So coming to the results, this is the baseline demographic distribution of the infants, showing the gender division on the basis of gender, mode of delivery, number of twins and triplets, and socioeconomic status, and they were not different significantly. Coming to the primary outcome, the refractive status of preterm and term infants at birth, the first table is showing at birth, and the second table is showing at the 12 months. At birth, we can see that most of the preterm babies were myopic, which was similar to the same at birth. At 12 months also they were myopic, and the term baby were hyperopic mostly. And when they were compared at 12 months for emmetropization, only 7 infants, preterm infants were emmetropized, and in term 13 were emmetropized, and it was not significantly different in both the group. Coming to the secondary outcome, among 45 total preterm infants, 5 infants had ROP. The worst staging was zone 2, stage 2, and mean spherical equivalent by age 12 months among 5 ROP infants was minus 0.25 with standard deviation of 1.81 diopter, and among the no ROP was minus 0.66 with standard deviation of 1.83 diopter. Independent t-test was conducted and showed no significant difference for ROP and no ROP with value of 0.64. So this is the correlation of mean spherical equivalent to the gestational age and the birth weight, and we can see that the birth weight is associated strongly than the gestational age. This is the graph showing the comparison of the mean spherical equivalent at follow-ups. We can see over here that the preterm baby, where the lower line is showing the refractive status at different follow-up or in the preterm baby, and the upper one is of term baby. The term baby are continuously tending towards the emmetropization, whereas in preterm baby, there is a dip till 3 months towards myopic shift, and then they are tending towards the emmetropization. So coming to the discussion, Larsen et al. And Saunders et al. Stated that among preterm with mild ROP or without ROP, there is myopic shift initially and delayed emmetropization. Pennefather P. et al. Stated that there is no significant difference between no ROP and stage 1 and 2 ROP. And Varghese R. et al. Also found that birth weight is more correlated to final mean spherical equivalent than the gestational age. So coming to the conclusion, preterm infants have tendency to develop myopia, whereas term infants hyperopia. There is no significant difference in immunopropagation among preterm and term infants at the age of 12 months. Among gestational age and birth weight is more associated with the final refractive status at 12 months. These are my references. Thank you.
Thank you, doctor.